Good afternoon. I am Dr. D.K. Nayak, Honorary Secretary of All India Ophthalmological Society. Welcome to the next edition of webinar, and today's topic is retinopathy of prematurity. We all know that retinopathy of prematurity is a blinding condition if not taken care of in the beginning itself. Therefore, the public education as well as education of the ophthalmologists are important apart from the neonatologists. So with this important topic, today's webinar is going to be covered by Dr. Anand Vinekar, who is a retina consultant at Narayan Netralaya, Bangalore. And he is going to cover whatever information that we need to do is for screening as well as taking care in the management part. So without wasting any time, I request now Dr. Anand. So welcome, Dr. Anand.
Thank you, sir. Thank you, sir. And at the outset, I'd really like to place on record my gratitude to the AIOS for this opportunity. This is a wonderful webinar series, and this being the Retina Month, thank you very much for this opportunity. I have no financial disclosures in any of the software devices or products that we use. ROP is actually, as Dr. Nayak mentioned, is a very emotional topic. If you get it right, you can prevent blindness. But if you get it even slightly wrong, then you are dealing with a blind baby. And when you look at a blind baby, but unfortunately, when you look at it in large numbers, it's just a statistic. So that's the sadness of this whole thing. When you have millions of blind babies across the world, it just remains a chapter in a book perhaps, or a program on just a paper. So despite massive advances in neonatal care, retinopathy of prematurity is still the leading cause of vision impairment across the world. And in India, this is probably the most preventable cause of infant blindness. The blue arrow is where India is. On your left are the richest countries, and on your right are the poorest countries. So we are what we call middle income. And middle income countries like India are suffering from the biggest part of this problem. More than half of the world's blind children live in India. When you look at it from a world perspective, India and China have two verticals of its own, as you can see here. And 1 out of every 5 blind babies in India are because of retinal causes. And believe it or not, about 80% of these retinal causes that are preventable come from just one single disease, and that's ROP. So much so is the problem in India and other middle-income countries that the WHO says we are suffering from the third epidemic. So what is this third epidemic? It's a mixture of the first and the second epidemics that happened in the United States in the 50s and the 70s. And this is such a gross underreporting of the number of blind babies from ROP in India that we are possibly reaching down that slope to more the countries which have this as a bigger problem, which is, let's say, Latin America and Eastern Europe. So why is ROP such a big deal and such a big problem now, when it probably wasn't so about 2 decades ago? And that's because neonatal care has exploded. We have wonderful neonatal care, not just in bigger cities, but in smaller towns as well. And with that, these babies are now surviving, and surviving with low morbidity. And because they're surviving, they're coming of age where they require ROP screening. So what's the problem statement? Even if we take a very pessimistic approach and say just 50% of those babies who are being born in India have access to neonatal care, and of those 50 who have neonatal care, we are now taking a further pessimistic approach and saying only half of them survive. Even then, more than 1 lakh of babies require screening every year. And more than 10,000 to 15,000 of these, this is a very conservative estimate, require treatment. To top it all, the United Nations a few years ago said that India leads in the number of preterm babies anywhere in the world. We are almost double that of China. We are 3.5 million, which is 35 lakh babies born preterm every year. And China is at about 11 lakhs. So that's the quantum of difference. So a very big problem, and the number of people to take care of it, just over probably 100. 100 ROP specialists, maybe a little more, and just concentrated in mostly the bigger cities, let's say about 15 of them. So somewhere in this 2 hours, every 2 hours, 3 babies require treatment for ROP, and that's the quantum of treatment, of the problem. The other problem that's happening is that smaller towns are now taking care of these babies really well. And conditions like what you're seeing on the screen here, which can possibly take the life of the baby, are now being taken care of extremely well. But somewhere down there is ROP, where they get screened very late, day 70 in this case, and we'll talk about when the correct time to do that is. So keeping a baby alive in an NICU can take a lot of money. But has anyone put a quantum on how much it takes to take care of a blind baby? Because a blind baby is not just one blind baby, it's an entire blind family. And the social and the moral problems that they have taking care of these are probably immeasurable. So we're talking about risk factors. It's just like diabetic retinopathy. The only well-known risk factor of diabetic retinopathy is the presence of diabetes itself. Similarly, for ROP, it's prematurity itself. Of course, there are others, and we love to blame oxygen. Just from the Indian subcontinent, more than 35 of these risk factors have been published. But none of them are cause and effect, and it's important that we don't really stress so much on risk factors when we're trying to get into a screening program. Now let's look at this video, which is a schematic, and this video, no, not this video. We'll go back to the previous video, please. Yeah. This is a schematic that I like to show non-medicos. It's very easy to explain to them how the blood vessels develop in a growing retina when we are still in our mother's wombs. So the blood vessels grow, and it's very easy to tell them that there's immature retina, and then a good proportion of them will actually stop there and cause disease. It's also very easy to show them that if you don't do timely treatment, how the entire retina shrinks. And I think this video is available on our website, and you can download it for patient education. But more importantly for us as ophthalmologists, it's important to understand how vascularization proceeds. The nasal ora serrata is where the blood vessels reach first, and that you see 8 is 8 months, so 32 weeks. In other words, any baby born after 32 weeks should actually have the nasal ora completely vascularized, and the temporal ora showing some amount of immaturity. And for that to have maturity, it should go all the way to 10 months or 40 weeks. Zones, there's a whole lot of definitions revolving around the zones. Postgraduates who are listening to this can refer to the NNF guideline or any standard textbook. What I really want you to concentrate now on the clinical aspects and not really theories and definitions. Zone 1 is what's right there in the center, which obviously involves vision the most. Zone 2 is slightly out there beyond Zone 1 and goes up to the nasal ora, and the crescentic remaining retina is Zone 3. Let's look at it from a clinical perspective. This is not to scale, but what I want to show you here is that even if the disease is right at the ora serrata on the nasal side, it is not Zone 3, it is Zone 2, because there is no Zone 3 in the nasal retina. Whereas the only Zone 3 in an eye is only on the temporal retina. And that's what I want to show you here. And this black oval shows you that we must also regard this nasal retina as importantly as the temporal retina. Because often in Zone 1, we're only looking around the posterior pole, and we fail to realize there's a whole lot of Zone 1 on the nasal side of the disc as well. So that's important, and that's what I wanted to convey here. Now let's start looking at what these stages look like. So here's part of it is stage 1, which is just a line of demarcation. And when this grows up and forms a sort of wall, we call it a ridge or stage 2. Clinically, when you're looking through an indirect ophthalmoscope, you're actually casting a shadow on this ridge, and you can actually make out that this is raised and actually has a length, breadth, and height. And that's how you know it's stage 2 and not a line. Whenever you have a combination of two stages in one eye, you must diagnose it as the higher stage. So this is stage 1 and 2, but on the file you must write stage 2 and not stage 1. This is an example of stage 3. It's not the classical one that we see in textbooks, but that's why it's here. I want to show you that this fuzzy neovascularization that is out of focus is actually stage 3. And we know that because it's extra-retinal, and that's part of the definition, which means it's growing outside the ridge and into the vitreous cavity. You may argue that part of this is stage 2 and most of it is actually stage 3. So by diagnosis, this becomes stage 3. Here is another example of stage 3, but here I'm trying to stress the fact that it is in Zone 1. And you often get loculated hemorrhages here. And in addition to this stage 3, what you're seeing here is a very classical plus disease. Although not classical in tortuosity, but very classical in dilatation. So dilatation and tortuosity of the posterior pole vessels is plus disease. So stage 3 with plus disease in Zone 1, this is something that you need to be treating maybe a few days, even before you saw this. So that's how serious this is. This may look like a ridge, but it's actually a fold of the retina, and that is a stage 4. When the retinal detachment is away from the foveal center, it's stage 4A. and when it involves the foveal center, it's stage 4B. And of course, stage 5, leukocoria, or a complete retinal detachment, is something we don't like to see, but which will happen if you don't screen and treat these babies on time. Typically, the lens is usually clear, and these babies are often misdiagnosed as congenital or developmental cataracts. So these are not cataracts, these are retinal detachments, these are funnel or closed funnel or some partial funnel retinal detachments, and they are retrolenticular masses. And there's, of course, differential diagnosis, one of them even being retinoblastoma. I just want to emphasize 2 or 3 atypical appearances. So this one, you won't really see a ridge. You actually see a whole lot of tortuosity, in fact more than dilatation, and a lot of vascular attenuation. And you'd agree with me that the blood vessels haven't even gone past zone 1. So this is an extremely severe case in what we call aggressive posterior ROP or AP-ROP. But the hallmark of AP-ROP is mentioned on this slide. You will see loops, these blood vessels going forward and then taking this U-turn and coming back. Of course, you will also see nodes, much like any vascular occlusion or diabetes, even in adults. And then you see hemorrhages, which may or may not be done, and you may not get a combination of all these in all eyes, plus disease, and of course it's very posterior. It can be either in zone 1 or posterior zone 2. And then you have what's been described from India as hybrid ROP from the PGI group. This is a combination of AP-ROP, which you can see here, and classical ROP, where you actually see the ridge and sometimes even stage 3. So when you get a combination of classical and AP-ROP, you call it hybrid ROP. These are probably the most difficult to treat. So how important is the anterior segment? Typically normal. This is a very poorly taken, poorly focused image, but I still want to show this to you because even taken from a regular phone, it's not even a red cam, you can make out through this hazy media that there is some problem at the pupil. So this is called tunica vasculosa lentis, a much clearer picture here, and it is like the equivalent of the NVI. And this has to be differentiated from persistent pupillary membrane. So this is a tunica vasculosa lentis that dilates a bit when you massage the eye. I'll come to that when I'm talking about treatment. And it's different from a more regular pattern which does not prevent pupillary dilatation. This one is persistent pupillary membrane and must be differentiated from TVL because TVL is a sign of very severe disease at the back. When we're talking about ROP screening, some of you all are probably involved in it and most of you all should be involved in it. The main problem is the mindset of people when you're initiating ROP screening, because I think everything else comes along, but getting into a neonatologist's office or NICU and saying we need to start ROP screening has certain myths. So let's explore those myths, because once you understand from a pediatrician's perspective what these problems are, you'll be able to convince them better and have a more successful ROP screening program. The first thing pediatricians feel is that they feel guilty about causing ROP, and you have to explode that myth. Because if they feel that the moment you walk in, you're diagnosing ROP in their babies, then they may not allow you to do so. So you have to give them data to tell them that ROP is just another side effect of them making these babies, keeping these babies alive. 10 years after PGI published its first prospective paper, they found that the incidence of ROP had not really gone down, despite the best neonatal care. But what decreased fourfold was the incidence of severe ROP, which means that if a pediatrician has to be told something about ROP, he should be told that you should reduce the ROP that requires treatment. You will not be able to reduce the all-stage ROP, and once they understand that, they're going to be more, they will allow you to probably, they'll accept the fact that ROP screening must be done. The second big problem we have, especially in some of our rural areas, is this whole fixation with oxygen. A lot of neonatologists believe that I have not given oxygen to this baby, it will not develop ROP, and so you don't even need to screen it. There is a problem with that. In fact, 1 out of 5 babies diagnosed to have treatable ROP in this country possibly have never had oxygen at all. And as I just mentioned about the risk factors, there are so many of them that none of them are cause and effect. So let's go with one criteria, which is the birth weight, and let's not put too much emphasis on oxygen. Talking about improving neonatal care and therefore reducing the burden of ROP, we did this study in some districts of Karnataka. At least this cohort was in a select set of districts which had probably the worst ROP. And we found that improving neonatal care in a period of 1 year, so we had 2-year period where the ROP incidence was very high, and then we improved neonatal care through general practices, and then we compared it with the incidence of ROP 2 years after that introduction, and we found that there was a very good reduction in the severity of the ROP. And here very classically what we found was the reduction in aggressive posterior ROP or AP-ROP. Let's look at these images. These are images from the improving the neonatal care era, where you actually see that some of these vessels have stopped short, there's capillary bleeding, looping, and then the vessel actually grows forward. So why does this happen? Why is there a looping and then there's a further growth? This happens because of variable levels of care. So what really happens here is a baby may be born in a small hospital, maybe in a town, and then the baby is somehow kept alive and sent to a district level hospital, probably a private hospital, and in this bargain the baby is given a lot of oxygen, an unmonitored 100% oxygen, because of which there's already vasoconstriction. So you have a part of the blood vessels that have got attenuated, then they go to a higher center and get better taken care of, hopefully, and then you have dilatation again. And then again there is a whole lot of probably oxygen requirement and other sickness factors that further cause the constriction. So you have attenuation, dilatation, and so on. And this bleeding appearance is very typical and it's almost only been reported from a few countries, India leading really. And this was very elegantly described by the Arvind group, which actually showed that some of these NICUs gave 100% unmonitored oxygen through the mask. And the damage that you can do to a baby in the first 6 hours is crucial. So even after 6 hours of giving unmonitored oxygen, if you take super care of these babies, they may still develop very severe aggressive posterior ROP. And what we found in this study is that we were able to reduce that incidence. The other thing is, especially the most senior pediatricians will tell you about not screening just because the baby is not heavier than 1500 grams, because they are going with the American and the British guidelines. And I want to say to you that about 23% of our babies who require treatment will be missed if you follow Western guidelines. So let's not ape the West here. In fact, this study published a few years ago, we found that almost 6% of these babies who required treatment were actually heavier than 2 kilograms. And remember, 2 kgs is the screening cutoff in our country. And about 1 in 5 babies were actually more than 32 weeks, which is why the national guideline now talks about 34 weeks as the screening cutoff. The other myth is this gestational age. Now the problem is it's all very good if you are very sure of the gestational age, but if a mother is not sure, then basing an entire screening program based on gestational age is a problem. So let's trust birth weight, because everywhere in our country, even in homeborn babies, somehow these babies get weighed by the ASHA worker or the A&M worker within a few days of being born, and I think using birth weight cutoff is far better than using gestational age. This was our first prospective report from rural Karnataka, from Kolar district, which showed that the incidence of ROP, both any stage ROP and treatable ROP, is just as high as any other city cohort published anywhere else in the country. So it's a wake-up call for us. The Hyderabad group has published aggressive posterior ROP in semi-urban areas, although this is the twin cities of Hyderabad we're talking about. And we found aggressive posterior ROP also in rural Karnataka, where we thought that these babies have to be really small or really tiny or be taken care of in the best centers in the city to have AP ROP. This was not the case. Another myth is, pediatricians will tell you, some of them of course, will tell you that I've been in practice for more than 30 years and I've not seen a single baby blind from ROP. Of course, that scenario is changing now thanks to the Supreme Court. But what this elegant study from Chandigarh shows is that none of the blind babies actually went to the pediatrician. They actually go doctor hopping to all the ROP specialists in this country, and that's the problem. And that's why we have to emphasize the fact that screening on time is the most important thing to do. So let's deal with some good screening practices. Until the new national guidelines, which are going to be released before the end of the year, hopefully, until then we have to stick to this one guideline, especially postgraduates who are listening to this program. If any of you all want this soft copy, I can email that to you. This is the 2010 guideline, so let me summarize it for you. Nothing much has changed in terms of the main grain in the 2016 guideline. So any baby born less than or equal to 2000 grams or less than equal to 34 weeks of gestational age must be screened. Of course, oxygen, STOMI postnatal course, all these other things are there, but they're not really caveats that we want to follow. When do we start screening? The first screening should happen between the 3rd and the 4th week of life. We are trying to modify that by saying that they should do at least one screening before discharge, because if you miss the baby and you have to screen much later, it becomes a problem. They may not come back. And babies born less than 1200 grams and less than 28 weeks must be screened even earlier. This is part of the guideline. I just want to emphasize again here that the first examination should be done before 30 days of life at any cost. So now let's look at this video. In this video, we're talking about how to actually examine this baby using an indirect ophthalmoscope. So most of us are going to be doing that throughout the country. The important thing here and the ease of doing it here is you can actually rotate the baby or you can move around the baby. Face the quadrant. In my experience, we use a Flynn depressor, but any small infant via speculum is good enough. And you must depress the baby, depress the sclera if you want to reach the ora serrata, if you want to do a complete screening. Although ROP that requires treatment can possibly be diagnosed without depression, but then that's up for debate. So an indirect ophthalmoscope, a 20 or a 28 diopter lens, a standard we use an antibiotic drop at the end of the procedure, and of course a topical anesthesia and the depressant, the speculum that we spoke about. The dilatation should be done about 2 or 3 times. Sometimes 2 times is enough, and about 10 or 15 minutes apart. If there's tunica vascular lentis, remember the pupil may not dilate, so do not overdilate. It can cause systemic problems. So how long do you keep screening these babies? You have to screen them till you see the blood vessels up till the ora serrata, and at least 1.5 disc diameters from the ora. Now, it is probably physiologically not okay to discharge an ROP baby from screening before 40 weeks, because you remember that's the physiological time at which it has to reach the ora serrata. Or if you see ROP, it should have regressed or on its way to regression. If you have any doubt, see these babies weekly. And when you want to discharge these babies completely, after their discharge, you must refer them to a pediatric ophthalmologist for other problems that preterm babies have, chiefly being refractive errors, lower vision, cataract, squints, glaucoma are actually more spoken of in preterm babies compared to term babies. Now talking about how to actually set up an ROP screening program. Let's do it monotonously. Same day, same center. You must go in there even if there are no babies. Because when you do this, you actually put in a whole lot of rigor into the system when they know you're going to come. So you must visit the NICUs that you're visiting on a regular basis and not wait for babies to walk into a center ad hoc, because otherwise the system really doesn't work out for a continuous follow-up of care. And as I mentioned here, you must refer your babies for longer term follow-up to a pediatric ophthalmologist if you're not doing it yourself. So as far as ROP treatment is concerned, I'm going to concentrate on laser, and then I'm going to touch on the aspects of anti-VEGF and a little bit of surgery before moving on. So whom to treat? This definition of threshold ROP is really required only if you're writing an exam. Today we don't follow that. We follow this early treatment recommendations, which means that any baby with stage 2 and plus disease must be treated. Earlier we had to wait for stage 3 with plus, but today we're waiting till stage 2 with plus. So we're treating a little early, hence the name. And the only time we will treat without plus disease is if it is stage 3 in zone 1. So that's important. Otherwise, you can see the treatment boxes come only when there is plus disease. So this is actually fairly easy to remember. Which laser? Traditionally the diode, but we've shown that the green works really well. In fact, probably has some advantages over the diode laser. The treatment, once you decide that this baby needs treatment, you must treat within 48 hours. And this has changed from 72 hours in the previous guideline to 48 hours now, and this is internationally. Best to do the treatment in the NICU or the step-down room of the NICU, or if you're lucky, you can do it in your outpatient with a friend who's an anesthetist or a pediatrician or at least a pediatric nurse standing by. So have a proper consent in a written and a proper format that has to be explained and signed. This is one of those risk factors that we found quite serendipitously while sort of screening for these babies. This was low platelet. This was that classical case of aggressive posterior ROP that I showed you, which spontaneously disappeared after correcting for platelets. And the reason why that happened in this case, and that's what this paper talked about, was how platelet transfusion given at the right time for thrombocytopenia must have reversed the anti-VEGF, reversed the VEGF load, because platelets themselves apparently have anti-VEGF-like properties. We're not recommending this as a treatment, but what I'm trying to show here is that some of these systemic risk factors must be looked at. Analgesia is extremely important. We'll get this video to play now. And what we are using here is that the classical description is 10% dextrose. It's hard to find, I'm sorry, 24% sucrose. It's hard to find. So what we find clinically is 10% dextrose. And as you saw in the video, as soon as the pellet of dextrose is placed in the baby's mouth, the baby quietened down. And this is not a placebo. Studies have shown that it actually reduces the pain threshold. It calms down the infant and obviously calms you down as well. Now the next video will show you how these babies have to be wrapped. It's very important because hypothermia is a major problem. Mummify is the word used. Some people take objection to that, so let's use the word swaddle. So when you're swaddling the baby, you want to be using a sort of a cotton or a linen cloth, not something nylon or synthetic that actually stretches out. You want to be separating the two arms, because if you keep both the hands together, these babies become extremely strong and they will separate out the sheets. And then you probably want to keep 1 foot out to place the pulse oximeter, as you saw in this video. When you want to treat these babies, the important thing is to have the adequate height. The most ideal height for you to be ergonomically stable is to keep your spine straight, and for that the height of the baby's head should be about 1 palm width below your umbilicus. So you'll be lucky if you find a stage or a plank where you can place this baby, but sometimes most standard trolleys in an NICU are sort of good enough. And once you place that, in this case we're using the top of a RedCam machine, you can actually rotate the machine, or you can keep moving around to all the quadrants that you want to face. Remember, face the quadrants. So if you want to laser at 12 o'clock, please stand at 6 o'clock position, and vice versa and so on. One sitting is what's recommended. Do the worst eye first, because in case the baby falls sick and desaturates, you can always come back for the other eye a day later, but if you've done the better eye first, you probably lost the worst eye. And always respect your neonatologist's opinion on this. If they say the baby is extremely unstable for treatment, you may be able to defer it, but again, do that within the physiological limits, if possible within 48 hours. The power obviously differs from a green laser and a red laser. In a green, you can start as low as 100 milliwatts, and the duration is about 150 milliseconds. And you want to keep the interval between two laser spots to at least double that of the duration. And this is important. So in other words, if the duration is 150 milliseconds, you want the next spot to come at least 300 milliseconds later. If you try to reduce that interval and do laser at a supposedly faster rate, the chances of causing cataract and thermal injury in these eyes is very high. So it doesn't serve any purpose in trying to do this laser faster. You don't gain any time. You must respect this rule of double. Now let's get this video to play, where the laser is in progress, and you're looking at me standing on the nasal side to probably laser the temporal side. You can do these lasers in a dimmed atmosphere, but of late we've been doing it with a good amount of ambient light. It's sometimes better to do that because you can look at the baby's systemic condition, and in case the child turns cyanotic or something, you can easily pick that up. The end of the video, you saw how we use these images to explain to the parents what we've done, actually show them the laser spots that have happened, and then they get very involved in the treatment and come back for follow-up. You should never count the number of spots. People ask what is the right number of spots. There is no right number. You do it till you have ablated, or rather covered all the areas that require to be covered. So everything anterior to the ridge and all avascular areas, even when there is no ridge, must be lasered. This is a montage, of course. The RedCam images don't look like this. And try to be as regular, and try not to make a very irregular scar. When scars heal as linearly as the one that you can see on this picture, you get a much better posterior pole, and you don't get narrowing of the arcade, and this helps in a long way when these babies grow up with lesser myopia. So the number of spots, and this has been described many years ago, these spots have to be either touching each other or almost touching each other, so that when they heal, they form what's called a syncytial scar. And again, this is that same picture blown up just to show you that as far as, so in areas here where my pointer is, you may not have a ridge, but this area may be avascular, and you must cover that area as well. Whereas here, there may be a very obvious ridge, and you want to be covering everything anterior. We'll deal with some special situations as we go along, but that's the way of standard doing it. Now, post-procedure, always watch for hypothermia and hypoglycemia, and observe this baby for at least about 20 minutes before you try to feed the baby. A half feed is more than required for the first feed. In this video, you are seeing how we are using these images to actually counsel parents. This is in rural Karnataka, and that's some of our teammates who are bringing the family in and showing them what treatment is being done and the importance of it. So coming back to the feeding schedule, do not feed immediately after the baby is treated. At least let a half an hour go, then do half a feed. Then the second feed can also be a half a feed, and then from third feed onwards, they're usually good. And keep the baby under monitoring and send this baby back if you are not admitting or if the baby is not an inpatient. Antibiotics and steroids are a very standard combination to give. You don't want to give it for more than 7 to 10 days. Nevenac or NSAIDs, controversial role, I tend to avoid them. Maybe it's just there in theory but not often used. The first time you want to see this baby after treatment, if assuming you've done a good job, is after 1 week. And the first thing you want to check there is to see whether there is no increase in the disease. So first you're looking for increase, and only then you're looking for decrease or improvement. So are there no skip lesions? Is the plus disease coming down? Good. Then the first week is done. In the second week, you want to look for how the spots are healing. Obviously the plus should not come back by then, and you should not see any remnants of the ridge. By 1 month, it's almost completely healed, and you can see this baby one more time before going into the long-term follow-up that we spoke about. So a couple of difficult situations. The first one being a small pupil. When tunica vasculosa lentis happens, you have two options. Either you stay patient, you start lasering one quadrant, and with the massage that you do, you'll start getting the pupil dilating only in that quadrant, and after some time, as you can see in the lower picture here, the pupil will dilate well enough for you to complete the laser. And otherwise, the other tricky situation is when these babies are sick and are still in the incubator. This is the laser through the incubator wall. You saw the scratches on the incubator wall. That is not going to prevent the coherent light source of the laser to go in. So don't wait for these babies to become all right, because by then this severe disease is going to turn even more severe. So you want to be treating these babies at the appropriate time. One other problem that we notice, especially in the really small babies, are the ones that have anasarca or low protein, is chemosis. So this chemosis can sometimes be so bad that they cover actually the limbus and go over the cornea, and there's no way you can proceed to complete the laser. At that time, you need your assistant to be using another depressor to slightly milk away the chemosis away from the quadrant that you are actually doing the laser. And slowly, as you can see this picture which says 20 minutes later, how the chemosis actually moved away from the limbus, and you're able to complete the laser very well. The aggressive posterior ROP, as I mentioned, is a very difficult entity, and I'm going to explain to you here how this is probably one time when you want to be doing laser in 2 sittings. So here is a zone 1 disease, where almost like a hybrid disease, which is there in nasally and temporally. And the important thing here is how you deal with the flat neovascularization. So when you have this flat NVE, the one that you saw superiorly on that picture, you want to actually be dealing with those as well, which means you must be lasering on the flat NVE. You have 2 options here. Either you laser over the flat NVE, as this graphic shows, because you have to take care of the ischemic retina underneath this, or you want to be lasering up to the flat NVE, wait for it to retract, and then go ahead and treat a week later. We compared both these options. Here you can see that you've treated up till here, this is retracted, and now you have this vacant area on which you must go back and do treatment a week later. So this is the second option of 2 sittings, and this is probably the only time you want to do it. We compared it in a study where one eye received a single sitting and the other eye received a 2-sitting session, and we found that the 2-sitting session was better, not in terms of final outcome, but in the chance of it causing any hemorrhage, because if you laser over the flat NV, the chance of petechial hemorrhages are probably more. Now let's talk about ischemia. The way you want to go closer and closer to the macula is you want to define the amount of ischemia. Here you have done laser a fair good amount, but you know you have to come a little more closer to the macula. You see a plus disease is reduced but not completely gone. And this, as you can see, is 20th of October. And you know you have to do a little more, but then let's say the patient misses follow-up. So you're just adding a little more laser, hoping that the patient will come back a week later. But in this case, the patient comes back almost 2 months later. And what do you see here? You see an equivalent of a 4A, which is a detachment in the macula. Now you have 2 options, either a lens-sparing vitrectomy, more laser, or wait and watch. Interestingly, this patient's parent was actually vitreoretinal surgeon. So I had opted actually for not doing any surgery and more conservative. So we actually put in more laser posteriorly. And I'm bringing this example because I'm going to be talking about posterior laser here. And fortunately, because it was done at the acute phase, this baby did really well, and both the NV and the traction went away, as you can see on these subsequent pictures. So talking about posterior to ridge laser, this is not standard practice, but has been described by the Canadians and by the Japanese, where not only do you want to laser the avascular retina, but you also want to put in some laser to the posterior aspect of the ridge, especially in these dirty areas where there's a lot of popcorn and a lot of ischemic areas. So the thumb rule is the amount of width of this stage 3, at least about 1.5 times that you want to go posteriorly, as long as the posterior most ray of this laser is about 1, 2, 3 disc diameters away from the center of the fovea. So that's what I wanted to convey here, that you don't go too close, yet these babies do extremely well. So that's a primary posterior when you do it at first shot. Sometimes you get babies who are lasered like this, referred to you partially lasered. When you know that not only you have to fill in this laser that was not done, but you might also want to do a posterior laser. And this is called a secondary posterior laser. And when you do that, of course you have to complete this area and do this. Within a week, entire fibrosis and traction goes away, but you need to remember that you have to fill it in, and then when you follow these babies, they do extremely well. In terms of anti-VEGF, the BEAT ROP trial, and I know a lot of us, probably a lot of people across India are giving anti-VEGF. There are some perils that I want to talk about. In our own practice, laser is done in about 97% of cases, and just about some rescue therapy we do with anti-VEGF. But I just want to share with you some of this. Now, this is that famous picture which says that there's a correct time to give anti-VEGF. If you give it later, you can actually cause tractional retinal detachments. And if you give it too early, you may not even be addressing the increased VEGF load. Dr. Azad brought out this wonderful editorial in the IGO where he spoke about the Hamlet's dilemma and why the BEAT ROP trial probably did not address some of these problems, where they were probably treating too late and the laser recurrence was so many that we don't see in India. In other words, he was saying that do not give anti-VEGF when there is so much unknown in terms of the risk factors. There are so many lessons from neonatology where they showed that what they believed to be the holy grail was not true, and things that were used as a drug turned out to be just the disaster that happened. And I'm not talking about just thalidomide here, I'm talking about regular stuff that had to be discontinued in neonatology. Let's just look at the pharmacodynamics. The body of the vitreous volume is so small compared to an adult, and yet we are happy just giving half the adult dose. So there's a problem there. The second thing is that the dosage that remains in the vitreous cavity is 10,000 times more than what is required to neutralize the VEGF in the vitreous cavity, and 1,000 times more in the serum, in the serum after it is given intravitreally. So that's the problem. Yes, there has been some theory about ranibizumab or Lucentis working better because of a smaller T-half or a T-half-life, but the problem here is a smaller molecular weight, and people believe that this may actually be leaking into the brain. This graphic shows you how these blood vessels, how the anti-VEGF remains so much longer in the vitreous cavity than the VEGF itself, and so it basically outlives its requirement. Most importantly, anti-VEGF is working exactly at the time where the organogenesis is happening. And so VEGF is required in certain roles, and if you are cutting off that VEGF, some of these important organogenesis may be affected. I want to share this video of one Avastin case that we gave. This is a very severe case of AP-ROP. You can see that 48 hours and 72 hours and a week later, the plus disease is going away, the blood vessels are beautifully growing forward. Keep your eyes trained on that week there. As soon as you see around 8 weeks or 11 weeks, you start noticing that there's a recurrence of the NVE. And in this case, about 2 months after the initial injection, we saw a recurrence of both the plus disease and the NVE. And by the time we got this baby to require treatment, and look at that, what's happening at 11th week. And by 3 months, there's even some bleeding. And these are the babies who require to be treated by lasers. The problem here is if you give away your anti-VEGF and send these babies away, it's asking for trouble. And the follow-up regimen is very, very strict. In the next video, this was exactly the reverse scenario, where we did the laser first, and then we did the anti-VEGF. So in this case, you'll see a very severe case of AP-ROP. This was in rural Karnataka, so we didn't have access to the injection even. And so we went ahead and did the laser first. As you can see, it's very messy. Despite that, we were able to get some laser in. And a week after that, it had bled. And we knew now that either we have to do more laser where we couldn't, or probably give an anti-VEGF. So that's what we did. Again, it was half to 1/3 the dose, as small as it can go through the hub. And within a week, we saw how it improved. how there was a wonderful recovery, the pupil dilated, the blood vessels spread out, the plus disease came down. But then I want to re-emphasize here that, and you're seeing that supplement laser done, it's important. It's important to look at those areas where the where the hemorrhages have really retracted, and you've gone back and addressed those areas, because if you don't, then there'll be a recurrence of the disease. So the Rainbow trial is something that is going to be answering our question. More than 35 countries across the world are now recruiting. There are several centers in India as well, and until next year probably we'll get an answer to that. So I want to just show you now quickly a baby who was treated more than 10 months before and sent to us for an opinion. He was injected and lasered. You may argue that the laser is not adequate, but other than that, this disease looks fairly innocuous. As you see these images moving a little fast. I want to show you what happens when you do the angiogram. See, the angiogram shows you what an angry plus disease this is and how the NV is still leaking. So with the innocuous looking fundus, you can sometimes get tremendous information from the angiogram, and you need to fill in these areas, and only when you fill in these areas, and you can see that this is bilateral. I'll quickly move through these filled in areas, and then when you repeat the angiogram, you see how the NV completely heals, and how the FAZ or FAZ heals so much better. And this is how, when you really take care of the disease. As far as surgery is concerned, stage 4A and 4B lens sparing vitrectomy is the surgery of choice, and in stage 5 you want to be doing lensectomy vitrectomy. I just want to talk about just the vectors that play a role. If you can play this video please, in this video, I just want to show you how the traction elevates from the ridge and goes up till the ora. And so you see these white lines, and these lines are coming from the ridge and going up to the wall, or what they call the eye wall, and then to the pars plicata, and these are the most dangerous ones, and then even retrolenticular. And as these ridges increase, you start seeing these tractional bands. And it's important to understand where these sometimes visible and invisible tractional bands are. And this horizontal one that you're seeing between the two ridges is called the drum head. And if you can open out that drum head, then you're improving the access to the optic nerve head. The retina then falls back, and you start getting a much more anatomical outcome than you would have otherwise. So in this vector case, you're seeing how these are being addressed in surgery. You want to be cutting first the ones that are attaching to the pars plicata, because these are the ones that have the highest chances of causing a phthisis. Then you want to be removing those tractional bands that attach from the ridge to the retrolenticular area, and then if possible do a deeper dissection of the drum head. This is a case that had a 4B, which was operated with lens sparing vitrectomy, and you see the retina going back, and this child had from a sub-TAC vision to 20 by 1000, which further improved with vision stimulation. I'm going to deal now with a little bit of OCT before I conclude with Tele-ROP program. Some of you all had written me mails about what I should address in this seminar, so I'm trying to include some of your requests. So a bit of the OCT now. Our initial experience of OCT has been with the Heidelberg, where we dismantled it and used it as a handheld. What we were able to initially demonstrate was flat neovascularization over the ridge, and you can see that here in an otherwise supposedly well lasered eye, and then you can address your laser exactly there, and we were able to show that the NV disappeared. But over the past 3 or 4 years, we've now had experience with the handheld OCT, and I'm going to describe some of that. So this is a standard adult foveal laser. A foveal OCT, where you see the outer plexiform layer coming and fusing with the inner limiting membrane, and all the layers of the photoreceptors here. But see what happens in a preterm baby. In a preterm baby, the outer plexiform layer is just going straight there without fusing. So this is called inner retinal immaturity or non-fusion. And here you see that even though the external limiting membrane is here, you don't see that hump that you want to see in the ellipsoid zone, or what was previously called the ISOS. So these layers are actually not present at birth. Now I'm going to move the next 5 or 6 slides pretty fast. I want you to keep your eyes trained on the 2 vertical blue arrows. So right below here at the foveal center, you're seeing just a single white line, which is the retinal pigment epithelium. But the 2 blue arrows are going to start showing you how the ellipsoid zone or the ISOS is growing from out to in this baby. So at 38 weeks, it's still far out. At 42 weeks, closer. At 46, even closer. At 47, it's almost 2 layers. And 2 months after the so-called expected due date of 40 weeks, this has now formed 2 layers. This means that preterm babies are not all born with all layers, and some of these layers are going to develop later. The main thing that differentiates an adult and an infant OCT has been the foveal pit, the persistence of that fusion, and thinner photoreceptors. So some of these layers actually code for vision. So if this fusion does not happen, you can have poorer vision. If this ISOS does not fuse, you can have poorer vision. And some of this has been published in some of the articles that I just showed below. Now, another thing that we found is in a stage 2 that did not require treatment, which is basically type 2 ROP, we found that about 30% of cases had this foveal disruption. This disruption could be categorized into two patterns. Pattern A, which had a massive foveal disruption with a large cystic spaces, and pattern B, with some of that foveal contour still being preserved. What's important is both of these patterns were transient and went away by the third corrected month. But when we followed these babies on for a year and had age-matched control, as this paper suggests, we found that those which had a larger foveal disruption did poorer in terms of vision, not just in the first 3 months, but all the way down to a year or more. And I think a lot of work has been done on OCT from the Duke University, which shows that not only vision, but other neurodevelopmental markers are also depressed in these babies with foveal disruption. So although it's transient, it probably happens at a very critical time. A new tool for imaging OCT for ROP has been the dye-less OCT angiography. So in this case, of course, this is the standard aggressive posterior ROP showing you on an angiogram what it looks like. But what we found on OCT angio was this flat neovascularization you see on the OCT image, and in the superficial capillary plexus you are able to correlate these to see exactly where these lesions are. Now the importance of OCT angio is for the first time perhaps we're able to see a deeper extension of this flat NVE in the outer retina and in the deeper retina. And remember that all this time NVI or NVD could not, the deeper extensions could not be seen because in standard angio they will leak. But here there is no leakage because there is no dye, and for the first time we are seeing deeper extensions. What is important here is we were able to laser exactly those FNVs, and then when we re-imaged, we found that the deeper extensions also disappeared. So we are now trying to coin a term that this is not flat neovascularization elsewhere, but this is a flat neovascular complex. I'm finally going to end with telemedicine or tele-ROP, as some of you all wanted to know how we're doing it back in Karnataka. There are some states already following this program. So I'm putting back two slides that I spoke about, and this is the need for telemedicine. There are very few ROP specialists, and a majority of this problem is happening in rural areas. So KIDROP is the name of the program that we started around a decade ago, and this is the Karnataka Internet Assisted Diagnosis of ROP, where we try to replace an ROP specialist with a technician who is trained to take wide field imaging. It's teamwork where telemedicine and training of ophthalmologists and taking together pediatricians and gynecologists happen. The requirement is very simple. You need a wide field camera, you need an SUV, and you need a laser unit. The team, as you can see here, are a bundle of all these kind of people. I'm going to start showing you, can we play the video please? These are very, very short videos that explain to you a day in the life of the ROP program. So that's the laser machine sitting at the back of the SUV, and the RedCam shuttle, which is the portable version of the RedCam that we have, that basically moves from center to center. And we have a fixed timetable to do that. In the next video, we're going to see how these, once you actually move into a neonatal intensive care unit, be it in the district hospital, sub-district level, or even the city, you are basically carrying out that RedCam shuttle and moving it into the NICU. And this, for example, is in northern Karnataka, where we're using a larger tempo traveler-like unit. The next few videos are going to show you how it's actually done. In the video on the top left, you're going to be seeing the ophthalmologist standing by your technician. That's the correct video, thank you. Standing by the technician who is actually imaging this with supervision. And that's how the training happens. So initially they are trained to take images, and not only take these images, but also read these images. In the video on the lower panel, you're seeing now an independent team who've already been trained and who are now doing it independently. So here, the person doing it is the technician, and the person who is with him is a manager. And they are continuously doing this this is actually happening in northern Karnataka, and this is independent of any ROP specialist or ophthalmologist with them. And I'll show you how that happens and how that accreditation happens, but this is the way they are deployed into the field. Now in terms of the enrollment strategy, we're going to have 3 simultaneous videos, so bear with me as they play simultaneously on your panel to the left. So what happens here is we've noticed, and I told you that how we want to rely so much on babies' birth weights. So here we have these babies, as soon as they are born, if the baby is born less than 2 kilos, the nurse will fill out a card. And this card will actually say that your baby is born less than 2 kilos, this baby requires ROP screening. And the bottom half of that card actually has the mother's phone number and the name mentioned, and she puts it in a drop box that you're seeing with her. And our project manager is collecting it periodically and calling up these patients to come to the nearest ROP screening site. And this is how, even if you go to 10 hospitals, you can increase your the drainage area to more than 20, 30 hospitals, because you can place these red cards in several NICUs where you can't physically go. And that's how this program actually is expanded to beyond the centers that we are physically present in. And that's that publication which spoke about how low cost this is, despite maybe calling them 2 or 3 times. And this is what happens. You can get patients from all over, not just the inpatients. Now, when these technicians look at this image, they will either look at an image and decide whether it is green, orange, or red. Green meaning completely normal, or the blood vessels have reached the aura. Orange meaning that there is some disease that requires follow-up, and red meaning requires treatment. Now, this is our training score. It's a very busy slide. I don't expect you to read it, but there are levels of technicians. So they spend 30, 60, and 90 working days with us, and with that they become so good that they're not only able to take this image but decide on even subtler disease. So here's an example of green, and this is possible because the technician is able to image the ora serrata very consistently. So you can discharge this baby. This baby, on the other hand, is red because it has stage 2 with plus disease. And remember, all these diagnoses are being made by technicians. And we're looking at our financial model. It's a Robin Hood system. About just 26% of our patients are paying the full charge, and yet this project is not just breaking even, but is actually viable to do because of the large numbers. On an average, we do about 1,500 screenings per month. Training is very extensive. They usually spend some time working on the mannequin, then hand-holding on the baby, and then eventually on the field itself. In the next video, you will see how we are using the entire RETCAM system to counsel mothers. So here is a captive audience of mothers waiting with their babies, getting dilated. You can actually use the help of your community medicine physicians and pediatricians to talk to them not just about ROP, but other wonderful practices like immunization, breastfeeding, and so on. Treatment, of course, because it's an emergency, either you should deploy your own people to go there, or must expect the baby to come into your center. I'm going to briefly touch upon the IT aspects. This video will show you how a technician who's captured these images is now uploading them onto a server, which is then now accessed on the smartphones or tablets of ROP specialists anywhere, sitting anywhere. So I could be sitting here and looking at images being taken in the periphery. This is despite our technicians have the ability to make a diagnosis on the field. We are still backing up these images on the server and looking at them as we go on. And we validated that system where we found that despite looking at them on a mobile phone, these images were good enough to actually come up with the diagnosis. So this video is rather long. I may not allow it to play fully, but just to show you how the drop-down menus on these images will allow us to report very directly. So we're getting the ICROP classification here. I'm looking at these images and I'm dropping down, I'm zooming, and then once I hit submit, the report goes back to the server. You can see that ROP reporting panel, and once you hit submit, it actually goes back to the server for the technician to read really real time. I'll skip on that video and go to the next slide, where we're looking at comparing our system with the American ROP system, a more recent program that started a couple of years ago, and our turnaround time was in minutes. Some of their turnaround times have taken a few days or a week or a few weeks, and this is because really necessity is the mother of invention, and for us this was the only level of care for some of our babies. And this is our area. We started our work in northern Karnataka, and now the whole state and about 103 centers are covered. The names are really not important, but I just want to emphasize here that it's a fixed schedule. So on any given day, that many number of babies are being screened. And we've covered about 85,000 imaging sessions, and close to 1,600 babies have been treated. Yes, this has got the eye of the Government of India. It's a public-private partnership. It's been rated by the RBSK. It's part of the national guidelines. The United Nations Development Program has marked this as a good practice for Southeast Asia and other countries. And very recently, the University of Western Australia used the CDC guidelines to actually validate the system. The conclusions are very interesting. It says that telemedicine or wide field imaging is probably the best way to take care of a problem of such a ROP in India, where there are less number of experts. And if you come down to indirect ophthalmoscopy, which is not done with proper trained people, it is fraught with medico-legal hazard. And these are the words I use from the report. So really pushing forward for wide field imaging. There are several countries that have visited us, and I know about 4 states in this country that we've been fortunate to be part of their training, and they're doing a wonderful job in their own regions. I'm going to end now with the future directions on where we see this program and this whole screening momentum going. The first one is that we have to contend with the fact that ROP is now a medico-legal disease. On July 1st, 2015, this Supreme Court order changed everything that we know about ROP. Overnight, health secretaries across all the states woke up to the fact that if you don't provide ROP screening in government centers or even private centers, you are up for huge amounts of medico-legal negligence. And after this case, there have been 2 more, the most recent one coming just last week from central India. The second paradigm shift is the fact that today we're going to be talking about not just ophthalmologists and technicians doing the imaging, but pediatricians and pediatric nurses as well. So here this will mean that you have to provide them with low-cost cameras. So the problems of scaling up to this, the first one has been the cost of the technology. A lot of you all probably know that the RedCam shuttle in India costs about $100,000 US, around that mark. So a Bangalore-based company came up with this device, and we've been fortunate to be part of the Department of Biotechnology grant where we validated this. Some of the this camera, we have no financial interest in it, but for the clinical aspect and validating the system. And we can see here that this camera, and I'm going to let this video play in full, it is wide field. For the first time probably we are seeing a low-cost LED-based camera that can screen up to the periphery. And as you can see in this video, this is not even edited. You can see that these, yeah, I'll take the questions, thank you. We'll take these, you're looking at these blood vessels reaching almost to the end. Of course, in this example, there is no stage of ROP, but I just want to show you how it can reach up to the periphery. So the quality has been decent. In this image, yeah, you can skip on that video, thank you. In this picture, you can see the same eye taken on the new camera and the same eye below taken on the RedCam shuttle. So it's good. There are certain limitations. We discussed that in a recent paper, and it's being submitted now, and you'll probably see the manuscript soon. The other big problem is this workforce. So how do we train this workforce? So we've come up with this entire training program to be portrayed online. And eventually we are thinking of having, this is of course a demo model where that person there could be the nurse, could be a technician, where he's actually live doing it, doing the imaging using any camera on a baby or a mannequin, and someone here is monitoring them live. There's also a society that's been created in India. Those of you who are interested in joining it, please email me. This is called the Indian Retinopathy Prematurity Society. It was all the stalwarts of ROP from this country are part of it. And we had a small workshop in Bangalore, and this momentum is going to grow. In the coming 72nd AIOS, we're going to have a small meeting for the IROP. For those of you interested, please contact me, and we'll include your names as well. The role of social media in increasing the awareness, especially among parent groups and people here. For example, there have been marathon runners who run in the name of increasing the awareness of ROP. All this is extremely important. And I just want to end eventually with the impact an ROP screening program can make. And politicians really understand only this financial worth. So I spoke about 1,500 odd babies who have been prevented from blindness. When we multiply their life expectancy and their per capita income, we are looking at about 450 plus crores of blindness person years that have been prevented through the program. And this may seem like a large number, but believe me, it's just a drop in the ocean. All of you who are listening to this, who are part of ROP screening programs and who want to be part of it, please, this country needs several more people doing ROP screening, and there are now very standard prescribed ways of doing it. And as I mentioned, the Supreme Court has now said that this is essential newborn care. So your pediatrician will come knocking on your door. And all this is possible only when you deal with a team. And I really want to acknowledge all the groups that we work with, some universities, the governments, both of India and Karnataka, and a whole lot of Indian institutes of both management and IIT, which have helped us a lot in our software work. And the best part about being in the ROP so-called business is the fact that your patients cannot thank you. And when they grow up and they see this beautiful world, and you know that you're a small but important part of that journey, that's the thanks that we all look for. Thank you once again from Team KIDROP, Narayan Netralia, and thank you very much AIOS for this opportunity.
Can we have the questions now on the screen?
So one of the questions is, what drops and dilution do you routinely use?
The name of the doctor as well and the location if it's given.
Okay. The doctor is Dr. Jagrup Singh. Dr. Jagrup Singh has asked the question, what drops and dilution do you routinely use for screening? Have you had any systemic complications because of dilating drops? And how do you prepare these diluted drops? That's a great question, Dr. Singh. Earlier you had to be diluting these drops. Phenylephrine 2.5% and cyclopentolate 0.5% is what's been prescribed and in the NNF guidelines as well. We are fortunate that the Orolab group actually makes these commercially available drops already diluted and mixed. So they are called OroPent Plus, and it may not be available in your regular retail pharmacy, but you can write directly to Orolab, and once you, or you can write to us and we'll get it across to you. The exact name and the details are available on the NNF guidelines, so we don't basically need to dilute again. As far as the systemic complications are concerned, if you use it just twice and about 10 to 15 minutes apart, we've not really seen anything. The one-off disaster that can happen is when there is over-enthusiastic dilatation by nurses who believe that they may be scolded for not dilating well, but actually in effect there's tunica vasculosa lentis. So you must instruct the nurse that despite diligently putting the drop, if it does not dilate, then there's possibly very severe disease, and then you will come in there and look. I hope that answered the question.
And I think also we should remember that when the kids we are dilating, because sometimes the kids are on the lap and they are lying flat with the face facing up. In that case, you put the drop and don't wipe out the excess.
Absolutely.
It will be unnecessary getting the pooled in the near the middle canthus, and gradually it will get absorbed in the system.
I think that's a very valid point. In fact, whenever you put the drop, in the other hand, you probably must have a cotton swab, and some people even talk about occluding the puncta for preventing systemic absorption. Probably that's not always required, but as Dr. Naik mentioned, definitely washing off the excess drop from the eyelid crease is very important. I believe Dr. Jaydev has asked the question, what are the expansion plans of KIDROP in the state, country and in the world? The KIDROP program was recently accepted by the CDC guideline, Government of Karnataka and Government of India. It's part of the now RBSK national program. Our training model has been used as an example for training other people to use it. Having said that, the rest of the states are looking at a low-cost camera and a complete foolproof method of making this available at their district headquarters. Centers in Pune, in Gujarat, in Ahmedabad, in Lucknow, in Telangana, and parts of Rajasthan have already adopted our program now for a few years in some of these centers. Madhya Pradesh, Chhattisgarh, I believe are the states that are looking at adoption in the coming future. And as far as the countries are concerned, on one slide I'd actually named some of those countries. Interestingly, even countries like Australia are looking at our model because they have this issue where the ROP specialists are positioned only in the larger cities, and in their counties you have these babies who have to be airlifted at government money to be just taken to one of the larger cities just for an ROP exam. So it's expensive and it works on the cost of the government, so they would rather obviously use wide field imaging or telemedicine to do that job. So in fact next month there is a big seminar in Australia discussing this. The next question is from Dr. Arvind Moria. He asks the question of anesthesia for examination. I believe you mean examination using indirect ophthalmoscopy or even through the RETCAM. Well, either way we use the topical anesthesia. We use proparacaine. It's usually commercially available, and I think all of us use it in our regular OPDs. It's 0.5%. The one we use is made by Sunways, but I'm sure there are other products as well. While doing the treatment, as I showed, we must use either sedation, but that's rather dangerous unless you have a good friend pediatrician or neonatologist close by, and you have to monitor the baby. So what we do is just the pellets of 10% dextrose. As you saw, it has to be a sterile pellet, it has to be wrapped in gauze and placed into the mouth. Some studies have actually tried to give it before the procedure. You can do that as well, but intra procedure we find works the best. And as they are suckling on it, they also hypoglycemia is also taken care of, because you see they are kept fasting for some time, and then they're suddenly brought to you for either an exam or for laser. So giving this dextrose or sucrose helps that aspect as well. So we almost have never done a laser under general anesthesia unless these are extremely big babies, 7 and 8 months, like that case that I showed you, which had received anti-VEGF and some laser and required treatment, was a year old. That one we gave a short GA, but otherwise it's always topical anesthesia. And there are several other comments congratulating Dr. Nayak and AIOS for this wonderful webinar series. Thank you very much.
Other questions right now we can't see. No, one thing then in the meantime is the more questions comes. Can I ask you one question? Sure. That how much you think we can prevent? Means there will be some cases which, even in spite of taking good care and all best possible care, still we may not be able to provide the useful vision. But then how much percentage we are going to make by our intervention?
So from a pediatric intervention, as the study showed, sir, we can reduce the incidence of treatable ROP at least to less than 5%. So less than 5% of those who have the disease will actually require treatment, and this is an offshoot from probably the best neonatal care practices anywhere in the world. And as far as our intervention as ophthalmologists and laser treatment or whatever treatment you're talking about goes, we have a success rate in India of more than 95 to 97% after laser, and I'm talking about all groups put together. In fact, there's been a very good debate on why our success rates are better than, let's say, Western data. As it's argued, we are a little more pigmented population, and the laser take, the laser spot take in a slightly more pigmented retina is both faster, and the effect that it has in terms of reducing the VEGF load is quicker. And since we're talking about a time-bound disease where the VEGF load has to reduce, probably that's why well done, adequately done laser has a much better success rate. So we can prevent blindness, first of all, in reducing the incidence of treatment requiring disease, and when they require treatment, just about 4 to 5% of these will actually progress to requiring surgery. And when it comes to surgery, if you do surgery at stage 4A, 80% of those can have reading vision. And when you're talking about 4B, as one paper suggests, about 40% of them can have ambulatory vision. So when you're looking at the end stage of bad stage 4B or clinical stage 5, we've really missed all these opportunities to make a difference.
So it means basically we are going to make difference in majority of these kind of child.
A huge majority.
Yes, yes. So that's something which is really heartening.
We have 3 more questions. Ideal dilatation drops for examining preterms with, yes, this answer was just given before this. So I will just repeat by saying that it's a commercially available drop called Oropen Plus. It's made by the Orolab group. Cutoff age for giving anti-VEGF. Okay, so as I mentioned, we are not great fans of anti-VEGF, and the cutoff age should, if you look at the BEAT ROP trial picture, you should not probably be looking at it more than 38, 39 or 40 weeks, because by then the physiological load of the VEGF itself is reduced, and you get an increased load of transformation growth factor beta. So what you're doing, if you look at it as a fraction of VEGF on top and TGF below, and you reduce VEGF on top, the denominator increases in effect, and it will go towards traction and retinal detachment, and the Mexican groups have shown that very well. And then the next question has been from Dr. Babu. How is laser applied? Is it by slit lamp, portable, or any other way? Okay, Dr. Babu, we covered that in the talk with some videos as well. It has to be given through indirect ophthalmoscopy, and slit lamp, I've only seen it being done by the Russians in a video, but not really live. But I think all cases in India are given through indirect ophthalmoscopy delivery. A green laser is what we prefer now, although diode has also been used. Dr. Usha asks, how do you deliver laser under topical anesthesia if the neonate moves his or her eye? Right, so again in that video we showed how we use the depressor to not just depress, you don't really need to depress the eye most of the time if you use a good speculum, but it's actually to immobilize. So when you use my personal favorite is the Flynn depressor. It looks just like a shortened via vectis. So when you place it at the sclera, what you're doing is you're bringing into view the edge of the aura, and so the best way to start out would be to mark out the aura so that you don't start accidentally lasering the pars area or the choroid, and then move more posterior up to the ridge. Definitely the baby will move his or her eyes on its own, and so that's why a speculum and a depressor is most important. Dr. Bhatt asks, where can we buy the Indian version of the RedCam and what is its cost? Okay, so I just mentioned that we have been the scientific partners to validate this device. I believe they have not yet sold it commercially. That's Forest Health, a Bangalore-based company. I think more details would be available on their website. And I was told unofficially that since the trial is over and we are submitting this data to DBT, they are ready for sale by the end of this month or possibly first week of October. But I advise you to look at their website. Dr. Bojwani asks the question, ILIA for ROP, any research? Yes, there is certainly some research on both Lucentis, which I believe some people in this country have already started using, and a couple of case report anecdotal experience with ILIA, but nothing that is nothing like in the form of an RCT. The only RCT that we're looking at Lucentis, which will hopefully answer these questions, will be the Rainbow trial. And I showed you a slide on that, and at least 4 or 5 centers, including a couple from Mumbai, are recruiting for that center. I believe globally they are falling behind the target, but I think by end of 2017 we'll start seeing some initial data. And yeah, a couple more people have asked ILIA and ROP, so I think that is the same answer. So what is the okay, Dr. Patel asked the question, what is the indication for anti-VEGF? So as of now, the indication will be a very severe zone 1. In fact, the new term called zone half is given, where in one of those pictures, if you recall, the blood vessels have not even reached the foveal center. So you can't really call it a zone 1. It's even half of that. So it's called posterior zone 1 or zone half, where giving laser here would mean overriding the fovea, so you don't want to do that. So that's one indication. The other indication is whether there's a media haze or an extremely small pupil, as Parag Shah's group showed, or you can give the anti-VEGF, the pupil dilates beautifully, and then of course in that case report they went ahead and completed the laser, but you can use that as primary therapy as well. And as Dr. Azad argues in that editorial, maybe if there is no access to laser or there's no confidence in doing the laser, then you can buy time by giving anti-VEGF. All I want to say is anti-VEGF works extremely well. I know some colleagues use it in many small towns and big cities in this country. But please remember that you have to have long-term follow-up on these babies. Even the BEAT ROP trial showed that there was a recurrence 16 weeks after injection. That is 4 months. In fact, the American Academy unofficially, and the guidelines are not out yet, but what they follow is a weekly for the first 3 months and a monthly re-exam for the first year. So if you are not sure of this kind of follow-up from your patients, either rural or semi-urban, then be extremely careful, because we have seen eyes that were injected and didn't go back for follow-up, and they've come back with stage 5. And in one case like that, one was a closed funnel, and the other eye, we did the angiogram, and we found the NVE persisting. This was this was not the example I showed, but another case where we had to laser this baby 8 months after injection. So things can be really bad, although dramatically they look very good. So those are really the indications for anti-VEGF right now. Half or 1/3 the dose, and giving about 1 to 1.5 millimeters from the limbus, not 2.5 or 3 millimeters from the limbus, as the BEAT ROP trial says, and that's also been argued very well in that editorial, because then you'll be going through the retina. Okay, I think a couple more questions on anti-VEGF asking around the same thing. So I believe we've answered the most of the topics.
So we had a fairly good number of questions, so I think since there are no more questions, so we can now call it a day. And do you want to give final some mark of caution, a word of caution, or some advice to the comprehensive ophthalmologists? They are practicing in small places or they're small
I
cities.
think the Supreme Court gave out that caution already. Today, the pediatrician, the entire burden of getting a baby screened for ROP has fallen on the treating pediatrician. But once they come into the care of the ophthalmologist, then the ophthalmologist is medico-legally liable. As the one medical negligence case came out of New Delhi and the other one last week from Indore, it is time that if you are involved in ROP screening practices, you have to now follow what is the national guidelines. Some of them will not be screening 1700 gram babies, saying that it is not part of an American guideline, but that's not true. Today, the government of India has said 2000 grams. So if you miss out on those babies and then tomorrow they can turn back and say that this baby should have been screened based on the guidelines and you missed it out. And the second thing is, I think some amount of validation and accreditation will be required. Part of the task of the Indian ROP group has to do that. I mean, we have set ourselves a task of all those people interested in doing and who already are doing ROP screening to be accredited in such a way that their names can be then hosted on perhaps something like the AIO's website and the government of India's website, so that even government patients who don't really have standard of care can meet that. So, and the final word of caution really is for the ones who are using anti-VEGF, and I say this again, it shows a very dramatic improvement immediately after injection, but please be very particular about the follow-up, and many of these cases will require a fill-in laser, and you must be able to do that.
So with this, since there are no more questions, I think there is one more question has come.
Dr. Falguni has asked, which tamponade do you use after vitrectomy? Just air exchange is more than enough. If you have to really be, if you have to end up putting oil, it means you've already caused a break and that's really game over. So you don't want to be doing that. As the graphic that I showed, the amount that you cut, the amount of the vectors that you deal with right initially, and then you make that initial nick to open the drum head. After that point, once you start seeing the opening of the drum head and the optic nerve head being visible, all you need to do is a fluid air exchange and then just close the eye.
So thank you, Dr. Anand Vinekar, for lovely informative webinar, and I am sure everyone must have been benefited with this. And if for those who have missed out, they can anytime watch it on our website, because all previous webinars are there available on our website. Anytime you can watch it. But I think the best time to watch it live, because that time you are really fully engrossed in this, and also you can ask questions if you have any doubt, because later on it will be difficult for you to ask questions. So I will recommend everyone that you should watch, and it's a weekly program, so it's not that something coming just out of the blue. So you can schedule your every weekly programs like this and watch it regularly. So thank you once again for watching, and thank you, Dr. Anand.
Thank you very much.